today's time, and much related to the videos that we had shared in the last weeks. We have Dr. Nidhi with us, who's going to be talking about a very pertinent topic in the post-COVID era, if I may call it that. And we're going to be talking about sudden cardiac events. This is, one of the, as I was just talking to Dr. Nidhi, this is one of the main thing that bothered Sir being a cardiologist. And, this is how the CRP less than one campaign was born in his mind. So, जितना भी हम सोचे कोविड के बारे में बात ना करें, somehow COVID does come up, and rightly so. I think COVID is here to teach us lessons about how to live our lives in a healthy way and to give us a new direction, towards a healthy lifestyle. So, without much delay, I would like to call upon Dr. Nidhi, who is the Secretary of IMA and NTB, and also the Associate Medical Director of PNP and the head of the Safety Committee in Shroff Charity Eye Hospital in Daryaganj. So, Dr. Nidhi, if you could come forward and throw some light on these very pertinent topics today.
Thank you so much, Dr. Meenakshi. So if you remember, we had said that, we'll do this COVID update for 100 episodes and then move on to a healthier lifestyle series. But unfortunately, we are seeing both as a part of the COVID spectrum and as a part of the post-COVID disease profile, things which are causing clinical concern for sure. But what is more concerning is that unless we adopt a proactive and searching mindset, unless we do something much more proactively, we are likely to miss certain things. And so as I was just telling you, that I have heard of at least 2 or 3 deaths in the last week or 10 days, which are otherwise unexplainable in healthy adults. And a sudden cardiac event in a 33-year-old, 25-year-old, these are unusual to say the least, tragic at worst, but these are asymptomatic people. So, so here goes. Let's see what we can do and how we can go forward on this very crucial topic. So Israel continues to puzzle me. Israel is the country which is the most vaccinated with the most boosters. Israel is still going up. India is the country with the maximum population, and it is, even though we find that the cases are rising, and we'll come to that in a little bit, it is still hugging the baseline. UK and US seems to be showing a slight downtrend, but it's going up and going down. They are now having newer variants of the BA variety. BA4 and BA5 are coming up in both US and UK. UK is distinctly going up. And if you follow the last 15-20 days, from 28th of May, India was at 1.7, let's say 2 cases per million, rose to 2.1, rose to 4.1, rose to 7.1. We're kind of doubling every week or so. UK started at 90, came down at 69, went up and is going up. Israel, as I said, is a puzzle to me, and I think I need to study it much deeper and come up with what's happening there. Absolutely unexplainable why Israel, with the least population out of this cohort, is showing the maximum cases with maximum vaccination. So if we look at the vaccination profile and the number of cases, let's say, Then US and Israel kind of share the same vaccination profile. They're both largely Pfizer vaccinated, mRNA platform. UK and India largely share the vaccination profile. Largely the AstraZeneca vaccine. India also has a bit of the whole virion vaccine, and UK also has a bit of Pfizer vaccine. So if you look at how the thing is, US, a slight uptrend, Israel, uptrend, India, close to the baseline, UK, slight uptrend. But despite whatever has been happening in the rest of the world, this part of Africa, least vaccinated, with the least medical facilities, also least tested perhaps, but we are talking about cases per million. It always tends to show the same 0 to 10 or 10 to 20 profiling. If you look at the number of tests per confirmed case, so you can say that India has been testing less and we just not testing enough. But if you look at 17th of May, a month ago, India had to conduct about 180 tests to get their first positive case. And today, India is at 45. US in the last 15 days has made masking and pre-flight testing unnecessary. Might change in the coming weeks or so, but they say that no more negative test required to board a flight and no more masking on the flight. If you want to do it, it is up to you. And we will come to why that might be what they are saying also. I'll come to that in a bit. So at 9, US has dropped all mandates. UK dropped all mandates despite this testing rate. Israel continues to follow the same protocols and principles despite being at 4. If we look at the effective reproduction rate, or the R0, India slightly above 1.5, which means that we are not yet at zero transmission. UK, again, hovering around 1.5, Israel hovering around 1.5. US has come down to 1, but it has still not come below 1. If you look at India's, India's effective R0, 18th of June, we had our R0 around 1.4. A week ago, it was 1.4. 2 weeks ago, it was 1.24. And 4 weeks ago, a month ago, it was at 0.8. Now, given this, if you're following it, it seems to be going up, and kind of plateauing out or maybe coming down, but we need another week or two to figure out whether we are going up or coming down. This is the period where, before a wave starts to hit us like a tsunami, that is the period to be careful. But if you look at global figures, US 0.1% rise, India kind of staying where it was, but maybe going up. Brazil 0.1%, France 0.3%, Germany 0.3%. These are the top 5 countries for global comparison. So COVID has not ended and probably will not be considered ended for a long time to come. However, endemicity is something that we will have to learn to absorb and live with. And where we say a disease has become endemic is at a personal level, at a public health level, and at an economic level. I think if at a personal level, we are able to carry on with our life with minimal disruption, despite what is happening around us, it is endemic. If at a public health level, the numbers are largely stable, showing pockets of emergence and pockets of resurgence and then going down, probably it has become endemic. At an economic level, if we are not stopping economic activity, if there are no lockdowns, and things are continuing to move, it is endemic. So look at India. So you see here, the curve is going up. This is somewhat similar in slope to what happened before the Delta wave. The rise of Omicron was much sharper. Now we don't know, or maybe even the first one, but we don't know whether this is going up or it is a bump and it'll come down. But for sure, if you look at the last 3 days, from 12,200 cases on June 16th, as against a 7-day average of 8,600, to 12,800 on June 17th, with a rising 7-day average at 9,353, to 13,216 on June 18th, with a rising 7-day average. So the 7-day averages are also rising. If you see here, the magnified part of the graph, this is this bump. This is this part of the graph. So rising. And what's more, the 7-day averages are rising. However, the recoveries are also rising, which is encouraging. But we are still too soon into this phase of rise, because even if we look at Omicron, we are looking at a 7 to 10 day lag between recovery and diagnosis. Again, a little detailed view on India. You look at the states: Maharashtra up, Kerala up, Karnataka up, Tamil Nadu up, Andhra up, Uttar Pradesh up, West Bengal up, Delhi up. The main brunt again seems to be Maharashtra, Kerala, and Delhi, which is, maybe these are the places which test more, these are the places which have more economic activity, these are the places which have more, we have been following these states. But going back to basics, if Omicron is, whichever variant of Omicron is rising again, if it is causing more disease numbers to be thrown up, what is the pathology? How does it work? Is immune escape working to make our future more bleak. Looking at how COVID behaves biologically. Stage 1, in the phase of infection and viral replication, where there is mild disease with fever, malaise, dry cough. Stage 2, where the replicated viral particles and immune response come into play and cause moderate disease with rising fever, pneumonia, with or without hypoxia. In the previous waves we saw, but in Omicron variants, we've been seeing that this is not happening. And stage 3, where there is multi-system, multi-organ involvement with respiratory distress and shock. Now, what we are seeing, even with Omicron, is that there is a new baseline of health. What I've been noticing is that whatever the chink in your armor, if somebody was pre-diabetic, after COVID, they become diabetic. If somebody was pre-hypertensive, they become hypertensive. If somebody was having issues with headaches, they have more headaches. If they had thyroid issues, their thyroid control is off. So whatever were the chinks in the armor are getting exposed. Largely, this seems to be a process driven by inflammation. But going deeper into it, we will realize that it's so everything is kind of connected like a web. And we are talking about health and fitness and inflammation and a lot of factors which are keeping us like a well-oiled machinery, functioning well, disease-free, and going on. If you look at the chronic inflammatory diseases like metabolic syndrome and type 2 diabetes, you realize that it shares a lot of features with post-acute COVID and long COVID. If we talk about chronic inflammation, we know that there is ongoing reduced inflammatory threshold. So a sudden trigger can push us into clinical inflammation. In COVID, cytokine storm is doing the same thing. In chronic inflammation, there are plaques, hypertension, hyperglycemia, damage to blood vessels. Cytokine storm is causing thrombosis. It is causing thromboembolic phenomena. It is causing a microvascular endothelium damage. So all these features are similar. Chronic inflammation causes disturbance of glucose and fat metabolism and causes loss of muscle mass. We are seeing that muscle hypoxia in COVID causes inflammation, causes electrolyte disturbance, and it causes loss of muscle mass. So if you look at each of the features which defines chronic inflammation, and you look at its parallel in COVID, you will find it. If you look at respiration, you look at blood and vascular system, you look at liver, you look at central nervous system, everywhere we are finding this dark gray is COVID and the light gray is chronic inflammation, which is why sir used to say that, let's talk about a simple one-line mantra and see where that takes us. So CRP less than 1 becomes even more important today. Now, the thing to answer is this increased cardiovascular risk a function of COVID and of the vaccines, or is it a function of underlying poor population health? As I said, Israel continues to puzzle me. This is a study from Israel. It is published in 2022. It is published on 28th April 2022, which is as recent as it gets for this larger study. What they did here was they checked the data from calls received from their national emergency helpline, the 101 number. They do realize that there are certain challenges to the conclusions that they draw from this study. They can't prove causality. It might just be an association, but they have compared 3 cohorts here. The normal pre-COVID times, that is pre-2019. The pandemic without vaccination, that is the early part of the pandemic, about 10 months. And the pandemic part with vaccine, that is about 6 months, from January 21 to June 21. Notably, this data does not include Omicron emergence. However, it is instructive that the data uses uniform diagnostic criteria. So, since it's involving calls made by people to the national helpline and is self-reported, there could be both underreporting or overreporting. I mean, we see that even in our systems, somebody just comes up with pain chest, we find the ECG is normal, but equally, we find people talking about discomfort in the chest, humne socha gas hai, and finding ECG changes on arrival 4 days later. So all potential cases were investigated thoroughly. The spectrum of presentation was asymptomatic to insidious to sudden acute cardiac syndrome like picture. They did want to explore whether it was related to COVID and or the vaccines. And they had these distinct study cohorts. Now, what really is the pathogenetic trigger? We know that Sir used to start all his talks by saying that COVID is a hyperimmune, prothrombotic, hyperinflammatory, acute viral infection with medium to long-term sequelae. This line, more than ever, is relevant even today. In my OPD, and I'm an ENT person, in my OPD, when I hear the patient, my first question to them is, are you vaccinated? My second question to them is, did you get COVID? You will be surprised that there is a distinct difference in the way even the patients talk to you when they have had COVID and when they have not had COVID. Now, adverse outcomes which are documented to be associated with COVID are thrombosis. This can, of course, then also involve the coronary arteries, or it can be dislodged thrombus from somewhere else coming into the coronaries, like embolism. The acute coronary syndrome has been associated with COVID in the past. Cardiac arrest and myocarditis are well documented. These are documented not just from Israel, but they are documented from the vaccine adverse event reporting system in the US, from the yellow card system in the UK, and from the UDRA vigilance in Europe, which reports similar profile of adverse cardiac events all over the globe. So these are associated with both the disease as well as the vaccine. So what are the diagnostic criteria? In this study, they followed uniform diagnostic criteria for evaluation of potential patients. The criteria involved description of circumstances of collapse reported by the caller, ECG obtained on an automated external defibrillator on site, the report of indicators of the cardiac event or acute cardiac syndrome observed by the responding paramedic, which included responsiveness of the patient and the breathing pattern on arrival in the hospital. This was more comprehensively covered by a 12-lead ECG, symptoms, that of chest pain or shortness of breath, relevant medical history, and physical examination findings. So these are in all cases which were included in the study. Now look at this graph. This is the first public health advisory around 11th of March 2020, when they said that you should get you should be careful of your health, that COVID is a public health emergency. These are the cardiac arrest calls or ACS calls received on their 101 number in the pre-pandemic era. This is the second public health advisory when their lockdowns started happening. Now, COVID is already here, right? This is March to say July. COVID is here. COVID is here. This is where the vaccines have started. Third public health advisory. Look at the cardiac arrest calls. This is the red line. And the gray line is the number of COVID cases. So if you look at the first wave, the second wave, the third wave, the fourth wave, here cardiac events actually came down. Here COVID is down, but the cardiac events are slightly up. Here COVID is up, but the cardiac events are slightly stable over the last 2-3 months. Over here it is down, but the cardiac events are up. But it's kind of moving in a standard deviation band of 2. Here in November 2020, the COVID is down before it starts rising up in January 2021. This is where you also have vaccinations. If you see, the first dose is this purple line. As the vaccination peaks, the COVID comes down, which is encouraging. But as the vaccination peaks, look at what is happening to the cardiac calls. The second dose is your blue line. Again, look at what is happening to the cardiac calls. As the vaccination goes down, the cardiac arrest and ACS calls go down and then start hovering around a new baseline. We are talking about a country which has uniform conscription, fit adults, all enrolled into the army for 5 years before they get out into the world. They are all vaccinated with first, second, third, fourth, and now fifth doses. We are talking about Israel's rates, if you saw on that first slide, going up even now. And we are talking about a country with the least population having the maximum number of cases, and that has data. to say that there is something under the surface which is not being exposed. If you see the data with more clarity, you get to see what is happening here. But more importantly, I mean, of course, this is an association, it is not causation. We don't know what is going on. Deeper work needs to go into it. If you see that this is suspected single vaccine for recovered individuals, यहाँ पर भी आप देखो कि जब ये वैक्सीन डोज अपनी पीक पर है तो कार्डियक अरेस्ट कॉल्स जो है वो कम है, एंड विद इन 2 weeks of that the cardiac calls are going up. This is what I would like you to see, and this is what makes me rethink everything of what we've been discussing in the last 2 years. This is excess mortality in Europe. If you look at 2019, this is before the pandemic, 15 to 44-year-old, this is the expected mortality, the dotted line, baseline. In the 15 to 44-year-olds in 2019, this was where the mortality, excess mortality was resting. Look at 2020. That's when the vaccination was not there. This is cumulative, and this is the number of weeks through the year. This is cumulative. But if you notice, week by week, it is kind of, the trend line is kind of flat. Before the vaccination, the trend line is sort of rising, explainable by disease. This is 2021. January 2021, we started vaccinating. Late 2020, vaccinations were being rolled out in Israel, in parts of Europe and US. Late 2020. Look at what is happening with the vaccine rollout. Initially, it is hugging the line, and then you see where it takes off and see where it ends. 2022, the present year, it is staying, excess mortality is staying higher than what it was in the previous 2 years. Ongoing inflammation, and this is in 15 to 44-year-olds. If you look at the 45 to 64-year-olds, which are otherwise a high-risk group for inflammation and chronic diseases, the trend is even more clear. This is 2019. Sort of, we could take that as the baseline rather than the dotted line. This is 2020. 2020 is when we did not have the vaccine. And this is 2021 after the vaccine. And this is 2022 when we seem to have come to a point where we're saying it has become endemic. This is a very interesting website. We'll see more of it when we finish. So statistics across Europe indicate that excess deaths in younger age groups have increased 9 times since 2019. What seems to be happening here? The virus seems to have changed the phenotypes in cardiovascular disease a bit. Arrhythmias definitely both increase and decrease in heart rate. heart failure of varying degrees, acute coronary syndrome in a lot of people much younger than what we were expecting and seeing pre-pandemic. But comorbidities seem to have resulted in higher prevalence of end-stage diseases, both for the kidney and for the heart. The impact of SARS-CoV-2 on prognosis of comorbidities is definitely significantly negative. So how does a COVID infection cause injury to the heart and cause an ACS-like syndrome? There are several pathways through which it causes cardiogenic shock. There is direct injury, of course. We know that the myocardium has ACE2 receptors, and the virus particles have been found in the heart muscle in autopsies of people who have died of ACS in COVID times. There is acute myocardial injury and acute myocarditis. There is increase in vascular inflammation, which causes coagulation abnormalities, which can cause acute MI. There is hypoxia with decreased myocardial oxygen supply, again, acute myocardial infarction. There is increase in angiotensin II with downregulation of ACE2 receptors with plaque rupture, acute MI. The downward spiral leads to heart failure and cardiac arrest. The immune injury with cytokine storm can cause plaque rupture, with pro-inflammatory cytokines again causing heart failure and cardiac arrest. There is the Takotsubo cardiomyopathy, specifically seen in acute conditions of stress due to sympathetic nerve overactivity and catecholamine release. The arrhythmias are there. So there are several things. Even psychological stress can cause cardiogenic shock through the catecholamine surge. So in COVID times, all these mechanisms seem to have synergistically worked and resulted in a 2 + 2 = 5 and not 4 scenario for us to witness. The Israel emergency call registers were specifically calls for cardiovascular emergencies. There was a definite increase in emergency calls for cardiac causes since January to May 2021. This increase was to the tune of 25% over the levels in 2019 and even 2020. The significant association was seen with the rates of both first and second vaccine doses. Remember, here we are talking about the mRNA vaccines. There is no association that these authors found with COVID-19 infection rates. Now, it is important to see whether we should be proactively looking for adverse events in young adults. We need to be mindful that things are not right. Using the unique data set from Israel National Emergency Medical Services from 2019 to 21, this study, and I'm quoting, aims to evaluate the association between volume of cardiac arrest and ACS EMS calls in the 16 to 39-year-old population with potential factors including infection and vaccination rates. You saw in those graphs that the curves are more closely hugging vaccination than disease. However, this is an association and more work needs to be done to explore this in greater depth. What really is acute coronary syndrome? Acute coronary syndrome is roughly divided into three parts. Here we are showing two, but into three parts. The ST segment elevation, no ST segment elevation. So ST segment elevated are called STEMI or Q wave MIs. The non-ST segment elevated with cardiac markers positive are considered the non-STEMIs, or with cardiac markers negative are considered unstable angina. If you look at what helps the heart stay healthy and what keeps the body healthy, they're all the dance of several systems which is coming into play, starting from hemostasis and coagulation to mitochondrial metabolism, to lipid metabolism, to endothelial function, and to extracellular matrix. If we look at these reds, poor mitochondrial health with increased ROS, increased inflammation with increased CRP are the ones that we can catch early. ROS can be rehabilitated with our nitric oxide exercise, NO dump exercises, CRP with a healthier lifestyle and parasympathetic zoning. So what are the non-modifiable risk factors? Age, gender, race, family history, these are non-modifiable. We know that Indians particularly are perhaps in terms of cardiovascular health and diabetes, a little more prone, a little earlier in life than, just excuse me a moment. Can you please get? I'm sorry about that. So the non-modifiable factors I said were genetic. I'll have to go back to the previous slide. The non-modifiable risk factors are gender, race, family history, which Indians seem to have the short end of the stick. Lifestyle habits like diet, smoking, low physical activity, stress are modifiable. The result of these lifestyle habits in terms of lipid and sugar metabolism, in control of blood pressure and obesity is modifiable. So individual prevention strategies and following a healthier lifestyle can improve the outcomes in general population. Time is critical in treating any acute coronary syndrome. We must activate emergency medical services, perform an initial assessment, note the type, quality, and location of pain, encourage the victim to chew one or adult or two low-dose aspirins. So this is what sir used to say, कि एक तुरंत aspirin दे दो, अगर नहीं भी है, तो भी this is not going to do any harm. पर अगर है, it is going to be life-saving. Loosen restrictive clothing, monitor vital signs, and know the location of the closest AED devices. Now AEDs are present everywhere, in malls, in schools, in hospitals, and be ready to start the CPR. In the CPR now, earlier we used to say ABC, in CPR now we say CAB. So getting the circulation running is the first thing, and that is why the chest compressions take precedence over the airway, and for a reason. I mean, if a patient is not breathing even for a minute or two, the hypoxic injury still may be recoverable, but not having circulation for a minute or two significantly downgrades the prognosis. The risk factor management involves lifestyle changes, good glycemic control, good blood pressure control, good lipid control, and cessation of unhealthy habits like smoking. In vascular protection, dual antiplatelet therapy and lipid lowering drugs, sir used to say ACS for ACS. So aspirin, colchicine, statins to be started and to be continued for as long as needed. The cardiac protection involves control and prevention of heart failure and active intervention for prevention of sudden death. This is better addressed by probably you all, because this is really out of my depth. But what I can see is that being proactive, being alert, we can pick up things and do things which improve outcomes for our patient groups. Here, the black ones are what can be started orally. The red ones are the ones which need IV route, but anticoagulation and dual anticoagulation along with aspirin are the way forward once we do decide that this patient is at risk. The differences between acute and chronic cardiomyopathies and rhythm disorders. So there are a lot of people who seem to be wearing smartwatches right now. And the smartwatch does alert you to rhythm disturbances. If somebody comes to you and says that he's not feeling comfortable because the watch is warning them of certain things, these are the people who definitely must see a cardiologist at the earliest. A 24-hour, 72-hour, 48-hour Holter monitor is the easiest way to pick up any arrhythmias and to start treatment in a timely fashion. Again, if we look at what could be the central mechanism, IL-6, and there is persisting cell damage even in the myocardium, which is mediated by ACE2 receptors. So if a COVID-19 patient is suspected of a cardiac event, shows dyspnea, shortness of breath, chest tightness, sinus tachycardia, or new arrhythmia, if there are features of cardiogenic or mixed shock, if there is feature of new right heart failure, do the bedside tests to rule out an acute cardiac event, initiate the ACS protocol, and do checks for sepsis-related cardiomyopathy, myocarditis, and stress-induced cardiomyopathy. These are all protocols that are followed in the hospitals. But what can we, as individual practitioners, do? We, as individual practitioners, can keep our eyes open, keep our mind open. If you look at what is happening, is the cases, number of reported sudden deaths in 2021 has nearly 1, 2, 3 become 4, 5 times. It is not it's not excusable to ignore this red flag. A COVID patient having a cardiac problem could be having myocarditis, he could be having congestive heart failure, or could be having an MI. The 7 to 27% patients of COVID have elevated troponins, and troponin is an easy test to do. If we feel that a patient is in an acute cardiac syndrome, even if we are not able to do the other tests, a troponin followed by an MRI, if anything suspicious is revealed, is mandated. So this, of course, is because I myself don't know much about troponins, but maybe Meenakshi can throw some light on it. But what I understood was that all skeletal muscle and cardiac muscle have troponins, but there are certain troponins which are specific to cardiac muscle. These are found in the myofibrils as well as the cytoplasm. And the three that we are looking for are troponin T, troponin I, and troponin C. The injured muscle releases troponins which get into circulation, which are then picked up on the lab tests. If we are looking at CKMB, which is again an indicator of muscle injury, it rises very quickly and falls very quickly, whereas troponin T, released by the cardiac muscle, rises almost at the same time as CKMB, but shows a very, very, very slow fall over the next 8 to 10 days. The LDH rises a little later, but stays sustained a little longer. So these three tests, CKMB, troponin T, and LDH done together, can give us a fair idea of where in cardiac health the patient is. We are also finding a lot of patients with elevated liver enzymes, but we must remember that these are not only sourced from the liver. That muscle injury can equally result in rise in SGOT, in LDH, and SGPT, and alkaline phosphatase. So in acute MI, the ST segment might be elevated, resulting in the STEMI. This indicates an acute infarction, and this generally drops to normal with time. The Q wave may be prominent. It indicates necrosis, and ST elevation with significant Q wave is considered a serious acute MI. The inverted T wave shows ischemia and is reversible. The ECG changes with the passage of time, and ECG is something that I don't delve in. This is something that I refer to the physician if somebody comes to me with ECGs. So whatever I'm saying here is what I'm reading from here. It is very easy to see these representative things, but when you're looking at that, it is better that a physician does what a physician does. I don't go into this area, but as this says, after 1 hour of an acute MI, ST segment would be elevated. After hours to days of an acute MI, the Q wave changes become remarkable. The ST changes have not yet gone back to baseline, but after weeks to months of AM, the Q wave will stay, but the ST returns to baseline. So if we have to see just one alarm point, I think the presence of a Q wave and ST segment changes from baseline would be a good start point. So what are the various things happening? And this is a very crowded slide. I don't like it, but there is not much I could do to declutter this slide, because the risk of death in these patients increases linearly. 7.6% of those dying with an ACS during COVID times had no history of cardiovascular disease, compared with 13.3% of those who had only history of CVD. So this is a significant rise in numbers of new cardiovascular events. Nearly 38% of these patients had elevated troponin levels. without clinical symptoms of ACS. And that is where, that is where I think we need to be alert. I don't know how much this test costs, troponins. I'm sure it is worth that little bit of investment. When somebody comes to you with unexplained features, just adding a troponin to the test battery might save a life. Because these are the patients who have elevated troponins with no clinical features of cardiac involvement. Those with both elevated troponins and history of cardiovascular disease are approaching 70%. We know that SARS-CoV-2 can cause destabilization of coronary atheromatous plaques. It increases platelet aggregation and has a higher risk of stent thrombosis. The reasons why the troponins may be elevated in COVID are a cytokine storm, a hypercoagulable state, and coronary microvascular ischemia. So, old age, comorbidities, systemic inflammation, coagulation abnormalities, severe disease and multi-organ failure, and immobility are risk factors for the cocktail of COVID with the heart. However, knowing that an asymptomatic person might be having elevated troponins and myocardial injury makes us wary of suggesting vigorous exercise towards the rehabilitation of a post-COVID patient. That is why we have been emphasizing that it has to be paced, it has to be gradual, it has to be largely horizontal and largely low heart rate training to begin with. That means yoga, meditation, walking, and then paced from 12 minutes to 20 minutes to 40 minutes, and then to raise the level of activity over the period of a few months. The complications of myocardial injury and myocarditis, of acute MI, of heart failure and cardiomyopathy, of persisting arrhythmias, of shock and arrest and venous thromboembolic events are real. What is more troubling is that heart disease risk is not correlated to severity of disease. So whether it is atrial fibrillation, sinus tachycardia, dysarrhythmias, whether it is pericarditis, myocarditis, inflammatory disease, or it is ischemic heart disease with acute coronaries, myocardial infarction, ischemic cardiomyopathy or angina, or more severe forms of heart failure, non-ischemic cardiomyopathy, these are all commoner after COVID and not related to the severity of disease. This is excess burden per 1,000 persons who had COVID, and their data is talking about how elevated troponin may be the red flag that sometimes gets missed. These people, Wali Ali, I think he has done the health record surveillance from US Department of Veterans Affairs. They have tested more than 150,000 health records of veterans who survived for at least 30 days after testing positive for COVID. There were 2 control groups, more than 5 million people who had used the VA system during the pandemic, and a similar number who had used the system before the pandemic. The acute heart failure, arrhythmias, blood clots are common in people hospitalized for COVID, and autopsy reveals virus genetic material inside cardiac muscle tissue. The athletes are not protected by their fitness. Being fit is not equal to being healthy. And this is what we must all understand, that the sheer muscle mass that an athlete carries requires work from the heart. Being healthy means having a good circulatory reserve, having good heart rate recovery, and having less inflammation. Their study showed that 52% more chance of having a stroke with history of COVID for up to a year. 78% of these patients had some degree of heart irregularity at 2 months after infection. 60% had signs of ongoing myocardial inflammation. 72% greater risk of heart failure in COVID group than in the non-COVID cohort. And in a small study of 26 elite athletes at university level, 4 out of these 26, that is 16%, had signs of prolonged heart inflammation without any symptoms. Without any symptoms. India is, as far as cardiac health goes, not a very healthy nation. Globally, the cardiovascular diseases and their outcomes have worsened by 25% since the year 2000. And 32% of all global deaths in 2019 were due to cardiovascular causes. 85% of the cardiovascular deaths that we did see had both a heart attack and a stroke. If we are looking at self-reported cardiovascular disease in India in the age group of 45 to 60, we find Haryana at its highest self-reported, 34%, J&K 33%, Delhi 28, Kerala 28, Punjab 32. Even the hill areas where, going up and down slopes, walking a lot, it's not small. The number is not small. Ischemic heart disease has stayed the top cause of death from 2009 to 2019 in the last entire decade. COPD has come up from the 4th to the 2nd slot from 2009 to 2019, and stroke has come from the 5th to the 3rd from 2009 to 2019. All these are general population parameters, but they alert us to the fact that we are not a disease-free, laid-back nation that we assume to be. The studies do indicate that the most common complaints of a patient presenting with a cardiac problem are chest pain, sometimes dizziness, coexisting diabetes and hypertension are common, and that 25% of the disease burden rests with people less than 40 years of age. In fact, about half of the heart attacks occur before 55 years of age. These are Indian data. 90% of the patients were male, 60% were smokers, 14% had coexisting hypertension, nearly 8% were diabetic, and 65% had low HDL. 65% had abdominal obesity. 32% had elevated triglyceride levels. These are all parameters of population health that we are performing poorly in. Not all battles are visible, but neither are all the victories. If all of us can take on this mission of CRP less than 1 and then do whatever it takes, whether it is lipid metabolism, whether it is metabolic syndrome, whether it is glucose metabolism, whether it is lifestyle habits of smoking and stress management, we are not going to see many changes at a population level. Our victories will start becoming visible only when the wave that we start becomes a tsunami. Thank you so much. I think that's where I end.
Thank you, Dr. Nidhi, and really a commendable effort from you. A very detailed slide, and some news for me. Whereas the troponin levels, it's a little distressing to see. It's something, even though we've been talking about COVID for so long, it's something that had completely, sort of. That's something that I had missed, that the troponin levels are increased in most of these post-COVID patients, or in these the patients who had COVID. And I said it's distressing because, there is some sort of myocardial injury going on, whether the patient is having myocarditis or whether he's having a heart attack, that's a much later stage. But the fact that there is myocardial injury going on, it's again, a big knock on our doors, and, a time to, I've been thinking about this for the past week, that COVID was here to teach us a few lessons. If, you just showed us how the mortality has changed, the causes of death have changed in the last 10 years. And if you see all the, infectious causes and all
They're going down.
they are going down, and these lifestyle diseases, they are the ones that are topping the list. And maybe, it's just steering us in the right direction. Sometimes uh, the calamities, they probably, they have a role. And just like that, just the COVID pandemic has been playing this role of steering us in that direction of good health. And you've captured everything, that all those pressure points that are there, you've captured them beautifully today. So a big thank you to you for all your hard work and your efforts. The floor is now open for questions. So if anyone would like to ask something or maybe discuss something, we'd be happy to hear from you.
Madam, we have seen the many patients coming from the Chardam at the pilgrim. They are suffering from the COVID infection. What is the reason?
Coming from?
Chardam Yatra, Kedarnath and Badri Kedar.
I don't know. COVID is a disease which is transmitted in person-to-person manner. I guess if there is one person in a group who is infected, he can infect the whole group. So, in as much as that is concerned, that could be one reason. The newer variants, BA4 and BA5, are showing significant immune escape. So even people who have been infected by BA1 or BA2 will continue to be susceptible to BA4 and 5. And that could be one reason. So I don't know. I think it's still not
2 years after the pandemic. Do you think that we should just stop fretting over COVID now?
Exactly.
About the infection, but yes, this is something that I have been thinking about, but still, the fact that it's causing myocardial injury and still causing myocardial injury. I mean, I agree that the Delta variant must have definitely, cost us a lot, even if it didn't cost us our lives. So I'm, that's fine. But even the newer variants, which are having a milder form of the disease, people are still having post-COVID. So, the fact that, I guess we should stop fretting about the infection per se, but then the after effects, I'm still a little concerned. I don't know whether to be in panic mode or not.
So interestingly, UK is seeing re-emergence of Delta, which is a matter of concern. And they are seeing definitely more BA4 and BA5 than Delta, but even one patient of Delta being the index case can cause another, and a cross between Omicron and Delta would be the last
disastrous
thing we want.
Yeah.
So while I've come to a point where I feel like personally, I don't know whether masking into eternity is the answer. I don't know whether the vaccines have really had any effect. If we look at this, vaccines are equally, at least the mRNA vaccines are equally responsible for myocarditis. So I don't know. They do protect against severe disease. They do improve outcomes. But mandating anything now is not the way forward. I think what we need to do is brick by brick strengthen the walls that the population can use as their protection. And those bricks, like, you follow that cheese model, the holes don't align and hence the whole population is protected. But with a seroprevalence of more than 98%, a seroprevalence of more than 99%, if you still see emerging variants, then there is something going on which is telling you that you're still in the dark.
And madam, what is the meaning of the VS system, as you have mentioned about the ATS?
So जैसे हमारा ECHS है या हमारा yes, ECHS exactly, the system that uses that gives free health services to employees of armed forces and the police and the paramilitary forces. ऐसे उनका veterans है. The VA system is the parallel of ECHS in India. And their VA system has very strong record keeping for a very long time. जैसे हमारा ECHS है ना सर?
Dr. Nidhi?
जी सर, जी मैम.
It's okay. I read somewhere that the people who've had COVID are more prone to reinfections. Why so? I mean, don't they get immunity?
So the BA4 and the BA5 are showing immune escape.
Right.
The people who have, that could be one way in which it is playing out. People who have had COVID think that they are immune. They are a little careless.
Right. That's the only explanation. क्योंकि मुझे समझ ही नहीं आया कि ऐसा क्यों है.
मतलब मुझे ये लगता है कि अब हम थक भी गए हैं. हम सभी तो थक गए हैं.
बिल्कुल, ये बात तो मैं मानती हूँ.
और हम ये भी, I mean, what we really need to look at also is that, as Meenakshi said, that just going by numbers, it's time that we stop doing that, because when we drop to say 2-digit, 3-digit numbers, and then we rise to thousands, it is 100% increase, 25% more than yesterday. Those are alarming.
Alarming, exactly.
But the numbers are still very close to the baseline.
Yes, they are.
We do have to be watchful, but we don't have to be alarmed. We do have to follow personal protection, but that personal protection has to be logically and scientifically driven.
Mm-hmm.
And हम सब लोग vaccinated हैं. तो अगर इम्यून एस्केप है और प्रीवियस इन्फेक्शन से है तो वैक्सीन से भी है, तो अब तो हम कुछ भी नहीं कर सकते.
Exactly. ये आपकी बात बिल्कुल ठीक है.
So I mean, what sir used to say, that personal lockdown over national lockdown, or over a state lockdown, is the way forward. Because if you know that you are immunocompromised, then you will just have to take that much more precautions. If I am a healthy individual who's been infected before, who's taken both the vaccinations, I might choose not to wear a mask. I mean, of course we are live and maybe I shouldn't be saying this, but if someone is had like a couple of surgeries, or if someone has had some cancer therapies and they are immunocompromised, then they now need to have the sensibility to wear a mask, because there are other diseases out there that might actually, not just COVID, but even other diseases that might cost you. So I think जैसा मैं कह रही हूँ बहुत टाइम से कि COVID is just here to teach us a few lessons. And that's probably the the outlook that I have. But
No, but
I don't know
feel,
how many.
But what I feel is, Meenakshi, that let's look at the basics. So the basics are that there are some things which are inevitable, there are some things which are modifiable, and there are some things which are preventable.
Right.
If we are looking at immune escape variants of COVID which are inevitable,
Mhm.
then the modifiable factors are that we minimize its impact on us, which means that strongly follow. So as I said, that COVID is exposing the chinks in your armor. If you're pre-diabetic, you land up with diabetes. If you are pre-hypertensive, you land up with hypertension. If you are a basically type A stressful personality, then you land up with all effects of stress, dyslipidemia, and everything else. So if those are the modifiable factors, then we pick up the factors which are modifiable and we start modifying them. This means that going back to the basics, doing 12 minutes of moderate exercise a day, doing 4 minutes of a nitric oxide dump a day, or 10 minutes of meditation a day is not too much of an investment into a healthy life ahead. Being mindful of what we eat and where we go and what is our footprint in the world is not too much to ask for when we've seen so much tragedy all around us. So I think that's where COVID is taking us.
Mhm.
That start breathing
Deep breathing.
and stop running. I think that's where it is taking us. जी
डॉक्टर
सर,
थैंक्स अ लॉट. आपने ठीक ही बोला कि हम सब थक गए, पर कोविड वायरस नहीं थका है अभी तक.
ये बात
ये
आप
हमें ध्यान रखना चाहिए. And
बिल्कुल.
one more observation that studies from neurological centers and by various vascular surgeons have also indicated increase in incidence of strokes and thrombosis anywhere else in the body, like limb ischemias and all. Incidence has definitely risen vis-a-vis the pre-COVID era. Does the vascular intima also have ACE2 receptors?
Yes, sir. Endothelium does.
Okay, so that explains probably.
So that is, yeah. So that is why abhi piche, I think this was a study which came out a year ago, matlab early into the pandemic, which said that COVID is not a respiratory disease; it is a vascular disease. So people who are investigating the basics are coming to, so it's a mitochondrial disease. It is a vascular disease. The acute viral phase is the least of our problems.
Yeah, so that is what I was getting at, that, we should stop fretting over that acute viral phase and, that, oh my God, COVID ho gaya, that needs to stop. And we just need to worry about the repercussions and, see if those, so now I'm just wondering if CRP can be that marker that can tell us whether this person is going to, so, post-COVID, whether this person is going to develop or not, that we do not have a proper marker per se, except of course there was a talk about monocytes, but I don't know how accurate that would be. So that's maybe that is the need of the hour now, to sort of look for that marker which will tell us if this patient is going into post-COVID or not. Yes, a baseline, a higher baseline level of CRP, I think that might be something that can alert us, but it's not a short thing yet. I mean, we don't have that many studies to report that. So I think there are no more questions in the chat box. I don't think there are any more questions here either. I'm asking.
Madam, how to prevent the cytokine storm?
Sir, cytokine storm ab nahi ho raha. So reason for a cytokine storm is that there is a hyperimmune reaction which happens when the body encounters a new antigen. the COVID virus now is not novel. Whether it is because of previous infection or because of immunization, we have now developed an immune memory of the antigens that the COVID is exposing us to. So the inflammation is there, but the storm we are not seeing as often now. The only way to prevent a storm is to be mindful that it can happen and follow the markers.
Okay, but what should we do in our regular life?
रेगुलरली तो सर आप कोई अगर इन्फ्लेमेटरी चीज एनकाउंटर नहीं करोगे तो स्टॉर्म तो वैसे ही नहीं होगा, बट दैट CRP less than 1 and
all the anti-inflammatory things that we have been propagating, good sleep, good 21 minutes of exercise per day, strength training twice a week, good hydration. So all those, 7 colors, 6 tastes, probably that's what would help with that. Circa ek mnemonic hai when gate pass from KK. So probably that can be the mantra.
Yes.
Probably.
Yeah. Okay.
So I think we can call it a day or a week maybe.
Much.
Thank you so much, Dr. Nidhi, for doing this with us. And a big thank you to all of you for joining.